Welcome to this comprehensive overview of transcatheter aortic valve implantation, or Tavi. This procedure has revolutionized the treatment of severe aortic stenosis, offering a minimally invasive alternative to traditional open-heart surgery. In this video, we will explore the pathophysiology of aortic stenosis, the indications for Tavi according to the latest American College of Cardiology and European Society of Cardiology guidelines, the detailed procedural steps, and the expected prognosis. Aortic stenosis is a progressive and serious condition characterized by the narrowing of the aortic valve opening. This narrowing is primarily caused by the calcification and fibrosis of the valve leaflets, which impedes the smooth flow of blood from the heart's main pumping chamber, the left ventricle, into the aorta and to the rest of the body. This obstruction forces the left ventricle to work harder, leading to increased pressure within the chamber. Over time, this sustained effort results in the thickening of the heart muscle, a condition known as left ventricular hypertrophy. While this initially helps maintain blood flow, it eventually leads to a decline in heart function, manifesting as symptoms such as chest pain or angina, fainting spells or syncope, and shortness of breath, which is a sign of heart failure. The decision to proceed with Tavi is guided by comprehensive clinical guidelines from leading cardiology organizations, including the European Society of Cardiology and the American College of Cardiology. According to the 2025 ESC guidelines, Tavi is recommended for patients aged 70 years or older with symptomatic severe tricuspid aortic stenosis. It is also the preferred treatment for patients at high surgical risk, irrespective of their age, provided their anatomy is suitable for the procedure. For patients with bicuspid aortic valves, Tavi may be considered if they are at increasing surgical risk and their valve anatomy is favorable. The 2020 ACC/AHA guidelines provide similar recommendations, favoring Tavi for symptomatic severe aortic stenosis in patients over 80 years old. For those between 65 and 80, a shared decision-making process between Tavi and surgical aortic valve replacement, or SAVR, is recommended. For patients under 65, SAVR is generally preferred unless there are compelling reasons for Tavi, such as very high surgical risk. Tavi may also be considered for asymptomatic severe aortic stenosis if specific high-risk criteria are met, such as a very high maximum aortic jet velocity or reduced left ventricular ejection fraction. The Tavi procedure is a minimally invasive approach, typically performed under local anesthesia or conscious sedation, often referred to as a minimalist approach. The most common access route is through the femoral artery in the groin. A guide wire is carefully advanced through the stenotic aortic valve into the left ventricle. In some cases, a balloon aortic valvuloplasty, or BAV, may be performed to predilate the native valve, making it easier to pass and deploy the new prosthetic valve. The new valve, which can be either balloon expandable or self-expanding, is then delivered to the site of the diseased valve. For balloon expandable valves, rapid pacing is often used to temporarily reduce cardiac output during deployment, ensuring precise positioning. Self-expanding valves, on the other hand, deploy gradually without the need for rapid pacing. Throughout the procedure, fluoroscopy and transesophageal echocardiography are used to assess the valve's positioning and to check for any paravalvular leak, ensuring optimal function. Tavi has significantly improved the prognosis for patients with severe aortic stenosis. For high-risk patients, Tavi offers significantly better survival rates compared to medical management alone. In intermediate and low-risk patients, Tavi has demonstrated non-inferiority to surgical aortic valve replacement. Patients typically experience a rapid recovery and a significant improvement in their quality of life and functional status. While Tavi is a highly effective procedure, potential complications can occur. These include a risk of stroke, which is generally between 1 to 3% paravalvular leak, and conduction disturbances that may necessitate the implantation of a new permanent pacemaker in 5 to 15% of cases, with a slightly higher incidence for self-expanding valves. Vascular complications at the access site are also a consideration. However, ongoing advancements in technology and procedural techniques continue to improve outcomes and reduce complication rates. In conclusion, transcatheter aortic valve implantation has emerged as a transformative treatment for severe aortic stenosis, offering a safe and effective option for a broad range of patients. Guided by evolving clinical guidelines, Tavi continues to improve patient outcomes, enhance quality of life, and redefine the landscape of cardiovascular care.